Hi, so I'm Summer May Finlay and I'm just having a chat with Mark Wenitong
How are
for
you?
the Loyalty Country. I'm good, Mark. How are you?
Good.
Can you introduce yourself just so those that don't
Yep.
know you, who's probably no one doesn't know you, but anyway.
Yep, Dr Mark Wenitong. My mub's Cubby in South Sea Island, and work in primary healthcare, policy, research stuff.
Yep. You have a deadly career, which I've heard about, and I have to say that very few people have done as much as you have. But one of the things that's come up at the conference in a couple of the presentations I've seen is about institutional racism. The premise of this conference, or one of the premises, is sovereignty.
Yep.
And thinking about the mainstream health sector, so Danella Mills talked about this morning, about how basically the mainstream health sector just can't deliver for our mob. Let's talk about that. Let's talk about institutional racism and its impact on our mob and what you want to see done differently.
Absolutely. Look, firstly, broadly, there's some fairly generic issues about this. So if you consider big, complicated organisations like jurisdictional health departments, if you look at this from a Harvard business perspective, so what kind of things do you need to do to change the way a big business does their business? And so you have to have a couple of things: processes and the culture of the organisation, those kind of things. For those big kind of organisations, you can't change that. So if you're trying to do something specific for a group of people, and you've got that massive organisation and you're trying to change that to be able to suit them, it's very, very difficult unless you've got a very high level, strong team that's running that. And the chances of us getting a high level, strong team inside a jurisdictional health department is low. So the next best thing that they talk about is a spin-off. So what you need is a spin-off, and a spin-off is dedicated people who are focused on this specific area, who don't apply those same culture and processes of a big organisation, that can actually do stuff that's proper. So this is why we have Aboriginal Community Control Services.
I was about to say, I'm like, doesn't this already exist?
Yeah, so that's the whole thing. The big issue here, though, is when we're talking about institutional racism in hospital settings, we don't have Aboriginal medical services that are hospitals.
No.
So that's kind of a big issue. And so in the previous things I've just done some.
Your next session get underway in 5 minutes.
Bloody damn.
Thank you.
Just a few minutes, please head to your next session.
So a couple of things that have come up when I've done some recent coronials into Aboriginal deaths in communities, this is primary healthcare, has been, look, the culture of some of these organisations is so inherently poor around the ability to treat, or even wanting to treat our mob the right way. And this is really disappointing from health professionals.
Yeah.
You know, I said in the last coronial, the lawyer said to me for the jurisdiction of the mum, said, you said there was racism, you know, what makes you think that? And I said, the building, the waiting room's called the cage, okay, of this clinic. It's got wire around it. So don't tell me like that you're prioritising our mob and their care and all the other stuff that we need for really proactive, real evidence-based care. So some of this stuff's about, you know, like for instance, the rheumatic heart disease issues and stuff like that. Rheumatic heart disease has an evidence base around how you approach that, and it has to be proactive. And we're talking about home visits, really proactive, reaching out to people. If the health department can't do that, then they should let somebody else do it, because they're not able to do that kind of stuff, and that's what it needs. And so I got some critique from some of those things saying, oh, well, isn't that patronising and not self-determination? I'm going, no, that's the evidence base for clinical. It's your evidence base, not ours. You're not practicing your evidence base, so you need to get your act together.
Yeah.
Those kind of things are happening all the time, and it's so difficult for us to get into those spaces and go, hey, no, we want people who care about our mob.
Yeah.
You know, we actually, them people up there in our communities, they know whether people give a rat's ass about them or not, and they know the attitude of people that come in. And so if we have people up there that are just there for the money, it's not going to work. We actually need people who are proactive and who care, and some of these guys, these departments cannot do that for whatever reason that is. Some of it is individual racism, and some of it's systems racism, and access issues and stuff like that. But it's all stuff that's addressable if people really want to address that.
Yeah.
I'm not convinced that that's the case with any of the health departments in Australia at a jurisdictional level at this stage. Even though I've worked with most, and there's plenty of good people that are on side, that doesn't change the system.
No.
You know, and the fact that we have now lots of people in the system, most are junior. Don't expect junior people to be fighting upwards, okay? Because their career trajectory will be severely disadvantaged if they're trying to punch upwards. So it's not up to them in the system to change everything all the time, particularly if they're junior or junior doctors, nurses, etc. It's up to the corporate and the strategic arm of the departments to actually do this properly, and they're not. The other thing that happens is, of course, is that we stop mining the data around the black data in these kind of hospital systems and stuff like that, which means that there's no accountability.
I was about to say, what gets measured gets managed.
Yeah.
So.
So those are the kind of things. And having said that, look, honestly, even the national standards and stuff that everybody's supposed to be onto, sign up to, and be audited every, whatever it is, 5 years or something like that, the National Quality Safety Mob.
Yeah.
The black stuff in that, from my perspective, gets deprioritised. Other stuff gets heightened in those audits. The black stuff, because often they don't have the experience, you're actually able to look at that. So this is the auditors.
Yeah.
We need to be doing our own auditing of these kinds of things, you know. There's no reason why peaks wouldn't. Peaks could do that in each state and territory. But the prioritisation of that's really important, and particularly now when new Australian standards are being developed around safety and quality and stuff like that. But they need to be applied, and there needs to be accountability. And even in some jurisdictions, I think they should apply those as NKPIs for the services, so they're accountable to those and report on them regularly. The black stuff I'm talking about, not just the clinical stuff, you know. So there's a whole lot of things I think we could do better, but it needs stronger levers.
Yeah.
It needs more than just nice policies that get developed. You know, I'm tired of beautiful glossy posters, you know, and everything. You know, we love our black folders and all that kind of stuff. That's all good, but it never hits the ground, the implementation, in a strong enough way that includes clinical performance indicators to say, no, you are doing badly. What are you going to do about that?
So one of the challenges, I think, is that, you've got, within a hospital system, you've got the administrators and you've got the clinicians, right? And both of them have come through the tertiary education. I'm currently an academic, and I don't think we're actually teaching people.
Yeah.
I don't think we're teaching people how to do this stuff well from a governance point of view, from a clinical point of view. They hear about country and they get the fluffy stuff and they take that, but they don't actually understand what that means in practice, thinking about what does cultural safety actually mean for my clients. And it's not just a poster on the wall or a little flag.
Absolutely, and it's not just making people feel comfortable when they come in. There's a whole lot of things. But do you want to know, like, we did consultation with quite a few remote communities around what they really wanted in a primary healthcare service.
Yeah, nice.
And we did it in their way, and guess what they said? We want kind people, we want people that care about us, and people that respect us. There wasn't much more than that. Like, so, you know, we took that back, and, you know, everybody wanted to write up different ways, and I said, no, that's pretty clear to any clinician or any policymaker, you know, what they need. Kindness, that's not hard, that's a human trait that should be inherent in health professionals.
Yeah.
If they're not getting that, we're just not getting even to the basics here, you know, of the whole gig that's health, you know. What are we doing? What are our mainstream systems doing with our mob? How come people are still being rejected, access and stuff like that? And I've had to deal with, you know, quite a few of our mob that have been kicked out of the hospital system for the wrong reasons. And had to go back in.
Sent home with Panadol and
worse than that. But you know, and the worst part about that, from my perspective, is especially when they're older people, they think it's them. That's internalised racism. They think they're just bad people. That's disgusting to me. And when I say to them, no, this is this is not about you.
This is the system.
This is them. Okay,
Yeah.
We're going to sort this out. But it saddens me that our mob will internalise that and say to me, no, they just think I'm a bad person. That's why, that's why they don't want me in the hospital. Those kind of things, just disgusting, I think. So there's a whole lot of work that we have to do around this, and with our own mob including our own mob, and their ability to push back a little bit and understand their rights.
Yeah.
And look, in some areas, I'd say, oh, look, let's just invite some litigation lawyers in.
Go hard or go home.
Yeah. Well, but what stops, services in central Sydney doing badly for their patients is because they know their upper class patients will sue the hell out of them.
Yeah.
And honestly, for a lot of our mob, we do that. We internalise it and go, no, we just must have done something wrong, and they mustn't like us for a real reason. That's disgusting. So I think we need to have some much stronger leverage, and my perspective, class actions.
Yeah.
I don't think post-referendum, there's very little room for us to move.
Yeah.
Working within the system, which I've done for 25 years, there's very little movement other than glossy posters. And people trying to do good things, don't be wrong, but implementation doesn't hit the ground in a way that's really useful and accountable. So if we're not doing that, nothing's going to change. And that's what I was saying earlier, even generically, it's a hard gig because, you can't change some of these big monsters that are trying to do urban, remote, everything all in the same thing. But the logical outcome of that is to say, hey, let's just invest in a spin-off that can do this stuff for us.
Let's just, invest in nachos.
Yeah, basically.
I think that's a nice place to end. Thank you.